Hello, hi, greetings everyone. Welcome back to the another session. Today, I think we are starting on hepatology, right? So we have completed nephrology successfully. I think now, after the four chapters, medicine is almost complete right now, and the only thing that is left is a little bit of hepatology and maybe some gastroenterology section is left. So I'll try to complete in another uh, 2 days or 3 days maybe. So I might not be able to take class on 28th. I think it's on Wednesday, right? So Wednesday I might not be able to take a session, but I'll keep you informed. So because I have some other commitments as well. Because this class is planned a little impromptu, so we'll plan on that. So Ashwin is asking for endocrine. Endocrine, I'll try to do it after some time. So I think because it's there in the app already, I'll try to do the like the most important aspects of endocrine, and probably I'll do the most important aspects of respi and hematology also if possible. So let us now consider finishing off the hepatology in the first place. So as far as hepatology is concerned, hepatology is quite simple. It's not that tough compared to other topics. The concepts are quite little, and you just need to know something called a pattern analysis. It's like neurology only. So you just need to know some patterns. So if you know that patterns, you can understand that this is going to be the disease. It's actually quite simple. It's not a big deal. So let us start with the first topic. So the first one is going to be analysis of the liver function test. That's what we're going to start with in the first place. LFTs. So LFTs are very important, especially in like most of the times in exams, the pattern analysis is what they're going to ask in the first place. So as far as the LFT is concerned, you start with hepatic enzymes, then you go for the synthetic markers, then you're going to go for certain other markers which are used in common clinical practice. First, let us see about the enzymes in detail. So you all know what are the enzymes that we have. So we have some enzymes that suggest liver cell damage. So we can split into enzymes that suggest liver cell damage. And second, probably we can think about certain enzymes that indicate cholestasis. Enzymes indicate cholestasis. So what are the enzymes that suggest liver cell damage? The question is for the audience. So initially, let us be interactive. After that, I'll start taking over. So what are the enzymes that suggest the patient is having liver cell damage? Only two enzymes we have, isn't it? So one is called as AST, that is SGOT, that is aspartate transferase, and second one we have something called ALT, that is alanine transaminase, that is SGPT, right? So we have again two markers of cholestasis. So one is going to be the alkaline phosphatase, that is ALP. We'll discuss about each and every enzymes in detail in some time. Don't worry about that. And at the same time, we have something called GGT, that is gamma glutamyl transferase. So these are the two most important enzymes of cholestasis. Apart from that, we have some other enzymes of cholestasis as well. Like for example, we have something called a 5' nucleotidase, which we are not going to discuss in a great depth, to be honest. And we also have something called a leucine aminopeptidase. These are also supposed to be markers of cholestasis. Leucine aminopeptidase. Then we have some synthetic markers as well. So we have markers of hepatic synthesis. So I can write synthetic markers. So to be honest, these are the basic markers of liver cell function, to be precise. So one, of course, is going to be the albumin, which is extremely important. And second one, we have something called a PTNR. So this is coagulopathy. So because liver produces so many coagulation factors exclusively, like except for the factor 8 and von Willebrand factor, majority of the coagulation factors are produced by the liver exclusively. In that, the most important are going to be the 2, 7, 9, 10. That is vitamin K dependent clotting factor. So PTNR is extremely important. It's one of the important markers of hepatic function. And at the same time, finally, we have one more thing which is not used routinely, that is called a cholinesterase, or otherwise referred to as a pseudocholinesterase, even though it is not used very routinely in clinical practice. Apart from that, we have, this is the point number one, that is enzymes, and number two, it is a synthetic function or synthetic markers, and number three, we have bilirubin handling as well. So this is something which has to be discussed separately. Bilirubin handling and excretion. So that's a separate entity. So these are three things that we're going to see whenever a patient is having a liver disease and suffering from some problem in liver. So we're going to see for the enzymes, we're going to see for the synthetic markers. At the same time, we're going to see for the bilirubin levels and bilirubin handling. So each and everything has its own importance. So let us discuss about that in some time. So to start with, there are certain few basic concepts that we need to know. For example, what is the first concept that we need to know is, this is the most important. So that is the fact that hepatitis is not equal to liver failure. Hepatitis is not equal to liver failure. Many students do think that the hepatitis means that the patient has got a liver failure. No. So hepatitis does not mean liver failure. So hepatitis just means it's a hepatic inflammation. Hepatic inflammation, that's all. But it never is equal to a liver failure. So to tell the patient is having a liver failure, you need to have some evidences. So especially the liver cell has failed means there should be some synthetic function problem. So the two most important problems of liver cell failure is coagulopathy and encephalopathy. That's all. So one is laboratory wise. So you're going to find it through PTANR elevation. So this is number one. And second is encephalopathy, that is mostly clinical, largely clinical. So whenever a patient is having evidence of liver cell dysfunction, like coagulopathy and encephalopathy, along with that, the patient is having problems that are suggestive of some problem in the liver, like bilirubin elevation or OTPT elevation. So then only you can call it as a liver failure. So just the presence of hepatitis does not mean the patient is having a liver cell failure. That's extremely important. And at the same time, hepatitis, most of the times it's like diagnosed in clinical setting by increased liver enzymes. So tenderness of the liver or no tenderness of the liver or enlargement of the liver or no enlargement of the liver does not tell you whether the patient is having hepatitis or not having hepatitis. So hepatitis again is mostly largely of a laboratory diagnosis rather than a clinical diagnosis. Most of the things in hepatology will be relying on the laboratory diagnosis rather than clinical diagnosis. Similarly, hepatitis is also largely a laboratory-wise diagnosing stuff, not a clinical diagnosis. And similarly, liver cell failure. So one point is coagulopathy, that is largely a laboratory diagnosis, and second is encephalopathy, that is largely a clinical diagnosis. So you know what are the normal enzymes? So let us discuss about that in some time. OT is there, PT is there. So usually they'll be less than 40. If it's in the 1,000 or 10,000 or 1 lakh, does not mean that the patient is having a liver cell failure. So to have a liver cell failure, I can tell 1,000 number of times that the patient should have encephalopathy and coagulopathy. If this is not there, then you cannot really tell that the patient is having a liver cell failure or not. So hepatitis is not equal to liver cell failure. Similarly, liver cell failure, that is ALF itself, is divided into something called acute liver failure. Second one is called a chronic liver failure. So as far as the acute liver failure diagnosis is concerned, so if the patient develops liver failure within a period of probably 26 weeks, according to many of the European textbooks, or probably 6 months, according to majority of the US textbooks, whatever maybe this say, doesn't matter. So if the patient develops a liver failure, so that is what we refer to as acute liver failure. So which means either the patient initially gets a jaundice, or if the patient develops a hepatitis, initially some evidence of liver cell injury. From that point onwards, if the patient develops a liver failure within a period of 26 weeks or 6 months, we are going to call it as a acute liver failure. So same thing, if the patient develops a liver failure, but it takes more than 26 weeks, or if the patient takes more than 6 months to develop liver failure, from the time of onset of probably a jaundice, or I can tell hepatitis, from the time of getting a hepatitis or a jaundice, if the patient takes more than 6 months to develop a liver failure like coagulopathy and encephalopathy. So this will be called as something called as a chronic liver failure. So right now it's very important to know that there is nothing called as a fulminant hepatitis or a fulminant liver failure. So most of the case of acute liver failure will be equated to fulminant hepatitis, or probably you can call about a fulminant liver failure. So when you encounter the term called fulminant hepatitis or fulminant liver failure, you have to be very sure this terminology is completely an outdated term. This is not the right term. This is only of historical importance. There is no importance of this particular term. So it just means that you're meaning a acute liver failure. Whenever the patient develops an acute liver failure, we are going to also call it as a fulminant liver failure, or probably a fulminant hepatitis. All these things means it's acute liver failure only. So there is, to avoid confusion, AASLD has been very, very clear, and they have told like there should be no other term used apart from the acute liver failure. That's all. So we have ALF, CLF, we know that. And at the same time, when the patient is having OT and PT of maybe 1,000 or 10,000, as I told you, that again doesn't mean it's the fulminant hepatitis. Maybe you can call it as a severe hepatitis sometimes, but it never means it's a fulminant hepatitis or an acute liver failure. So let us move on and discuss the enzymes from now on. So after knowing the basics of what we need to know. So first is the enzymes of liver cell injury. So that is your ALT and AST, which is very important. Suppose if somebody asks you what are the normal AST and normal ALT levels, it is always less than 40, usually. As per the guidelines by different laboratories that we see around the world, less than 40 is considered to be the normal AST and ALT. First of all, you need to know that AST is something quite non-specific, even though it's a marker of liver cell injury. It's quite non-specific, whereas ALT is supposed to be very specific for liver cell injury. And remember why it is specific, because it's seen predominantly in the liver. It is still seen in some areas apart from the liver, but it's predominantly seen in the liver only. That's why it's very specific. And at the same time, AST, why it is non-specific, because it is seen in other areas apart from the liver. It is also seen in red blood cells. It is also seen in heart. We know that it is also seen in muscles. It's also seen to small extent in kidneys as well. So apart from the liver, it is seen in many different areas. So that is why it is considered to be a little non-specific, especially in patients who are having hemolysis or maybe rhabdomyolysis or even a myocardial infarction may have an elevation of aspartate transaminase. Remember, aspartate transaminase is also called as SGOT. You know what do you mean by GOT? This is glutamate oxaloacetate transaminase, and ALT is also referred to as SGPT. GPT we know is known as glutamate pyruvate transaminase. We know that, so we don't want to tell what reactions they are actually taking part in. So similarly, AST has two different types of AST within itself. One is called the AST of mitochondrial type, number one, which is the one that is maximum 80% of the AST will be of mitochondrial type only. Second one, we have something called AST of cytosolic type, which is contributing to only 20%. So if they ask you which AST is going to be prominent in the liver cell, it is going to be AST of mitochondrial type. It is not AST of cytosolic type in the first place. Okay. Apart from that, ALT, there is no mitochondrial or cytosolic business. It is 100% cytosolic. It is not mitochondrial at all in the first place. It's always cytosolic only. Similarly, the half-life is quite different. The half-life of AST of mitochondrial type is actually greater than the AST of cytosolic type. AST of mitochondrial type half-life is approximately 87 hours, which is the largest compared to all the liver enzymes. And the AST of cytosolic type is going to have a half-life of only 17 hours. But the half-life here, because it's only one form is there, it's only cytosolic form, the half-life is approximately somewhere around 47 hours. This is the half-life of ALT, alanine transaminase. So we know the reaction catalyst. I'm not going to write the reaction catalyst because it's a pure biochemistry. You can go back and learn that. And similarly, there are some conditions where AST can be elevated. There are some conditions where ALT can be elevated. But please understand, whenever AST and ALT is elevated, there are some differential diagnoses there. So number one is always, we know there is a liver injury or liver cell injury. I'm talking about injury, not failure. So injury is different from failure. So liver injury is what is happening. Second, we can talk about a cholestasis. Even in severe cholestasis, your AST and ALT can be elevated, but even though the pattern is important, which I'll show you in some time. So, but usually in exam, whenever AST, ALT is elevated, we talk about some evidence of liver cell injury, but cholestasis itself can cause some liver injury. So that is the reason why even in cholestasis, AST and ALT can be elevated, but always remember it is a marker of maybe more than writing a liver injury, we can write as hepatocellular injury. It's a hepatocellular injury or some form of hepatitis is going on. So this is what we are talking about. So similarly, they will be asking one more scenario where AST is elevated, but ALT is completely normal. So these kind of scenarios happen in situations where there is actually no liver injury here, or no, I can write no hepatocellular injury. No hepatocellular injury. At the same time, this is not cholestasis also, but at the same time, this is an extra hepatic source of AST elevation. So which means AST is quite non-specific. So it is coming from some other area. So for example, it could be hemolysis. It could be, as I told you previously, rhabdomyolysis, or even it could be an acute myocardial infarction. So there are some other situations where you can have a AST elevation alone, but ALT is normal. Suppose in exam they ask AST alone is elevated, but ALT is normal. You generally think about a extrahepatic elevation or extrahepatic source of aspartate transaminase. That is actually the likely reason for this AST elevation. But ALT is more specific. So if it is normal, we can exclude a liver cell injury. On the other hand, they will be asking about one important ratio, that is the LDH-AST ratio. Usually in patients with hemolysis, the LDH-AST ratio will be more than or equal to 30 most of the times. So even though the AST is elevated in hemolysis, the LDH is the one that will be predominantly elevated in patients with hemolysis. So typically the LDH-AST ratio will be more than 30 in patients with hemolysis in the first place. And at the same time, even in acute myocardial infarction, your LDH may be elevated, but you know what LDH will be elevated in acute myocardial infarction? The LDH1 will be elevated compared to LDH2. That's what we refer to as LDH flip. Normally in hemolysis, even though if LDH is elevated, still the LDH2 will be more than LDH1 if it's a hemolysis. But in acute myocardial infarction, the LDH1 will be elevated compared to that of LDH2. So these are very, 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 very old questions, to be honest. So I don't think in the current pattern of questions, you will get these kind of questions, but nevertheless, it's better to know. So LDH1 more than LDH2 in acute MI, that is what we refer to as something called as a LDH flip. So these are the causes of where AST only may be elevated, where ALT can be completely normal. So depending on the pattern of elevation, we have some things we can understand based on the AST-ALT ratio. Suppose if the patient is having AST and ALT elevation, AST and ALT is elevated, both are elevated. And if it is more than 3 times the upper limit of normal, so if it is more than 3 times the upper limit of normal, you know what is upper limit of normal, it is 40. So usually you take 120 approximately, but it again depends on your particular laboratory. If it's more than 3 times the upper limit of normal, then clearly I can tell there is a definite hepatocellular injury. And if there is an hepatocellular injury, what is the type of hepatocellular injury will actually be dependent on the ratio of AST and ALT. Suppose I'm going to see AST and ALT ratio. Suppose if it is less than 1, or if AST and ALT ratio is more than 1. Suppose if I'm talking about AST-ALT ratio less than 1, usually we call it as, it is hepatocellular injury of inflammatory type. It's an hepatocellular injury of inflammatory type. Suppose if I'm talking about the AST-ALT ratio of more than 1, I'm talking about a hepatocellular injury of post-necrotic type. Hepatocellular injury of post-necrotic type, number 2. So this is what I'm talking about here. So what are the conditions where you will get a hepatocellular injury of inflammatory type? So usually you will get in an uncomplicated hepatitis, just a simple hepatitis, uncomplicated hepatitis, you're going to get a AST-ALT ratio of less than 1 only, which means in this situation, the ALT levels are actually more compared to that of AST. Yes, that's what happens in an uncomplicated hepatitis. Typically, characteristic example of an uncomplicated hepatitis is a viral hepatitis. Maybe acute viral hepatitis or probably a chronic viral hepatitis, doesn't matter. So in viral hepatitis, you're going to get an uncomplicated hepatitis. And second one, we have something called NAFLD, that is non-alcoholic fatty liver disease, where you can have an uncomplicated hepatitis resulting in AST-ALT ratio of less than 1, where ALT will be more than AST. And third, very rarely you can get in cholestasis, but still we have already discussed about AST-ALT more than 3 times the upper limit of normal. So it must be a true hepatocellular injury rather than a cholestasis. Similarly, if AST-ALT is more than 1, so in this situation, the AST is actually more compared to that of the ALT. That's why the ratio is more than 1. Typical example of this in exam is usually an alcoholic hepatitis. This is a classic example, alcoholic hepatitis. So where we typically have the AST-ALT ratio of approximately more than or equal to 2. That's called 2:1 ratio. This ratio is what we refer to as a famous de Retz ratio, so which is what you see in patients with alcoholic hepatitis. And it can be seen in patients with fulminant liver failure. So remember, whenever I tell fulminant liver failure, it just means an acute liver failure or a severe liver failure. Or we can get in patients with cirrhosis, complete cirrhosis. Usually this is something which is very important to know. Usually in patients with cirrhosis, the AST levels will once again become more than ALT. Very commonly we have seen in certain patients who have a chronic hepatitis. For example, I'm having a chronic hepatitis B. So I'll be having a AST ALT ratio of persistently less than 1. So suddenly, like I'm following up the patient after maybe the patient has lost to follow up, discontinued the treatment. Maybe after 2 years or 3 years is coming back to me again. And now I'm taking an LFT where AST ALT ratio has become more than 1. So in this situation, usually I think about a cirrhosis. So the patient initially was having a chronic viral hepatitis. Now he has progressed towards a cirrhosis. The moment the patient goes for cirrhosis, very often your AST values will become more than ALT, which is a very important pattern that we need to know. At the same time, if the patient is having a hepatocellular cancer or probably a metastasis, usually your AST values will be more than ALT. So please understand one more thing, that in HCC or metastasis, typically you won't see a hepatocellular injury type of pattern. But I don't know for how many people it will be surprising. Usually it will produce a cholestatic pattern only. Cholestatic pattern only. It will not produce a hepatocellular injury type of pattern at all. Most often, the space occupying lesion in the liver is going to produce a cholestatic type of pattern only. So why I told you is in HCC and metastasis also AST will be more than ALT only. But since it will not produce that more than 3 times the upper limit of normal kind of a value, so I can rub this off and I can just tell here. But remember, hepatocellular cancer and metastasis, any space occupying lesion can have a AST value more than ALT, but they will not satisfy this rule, that is more than 3 times the upper limit of normal, and they will produce more of a cholestatic pattern. Even though AST is more than ALT, doesn't matter. It will not be more than 3 times the upper limit of normal. That's why I've rubbed that particular cause from this list. So whenever in exam they ask you what are the causes that produce inflammatory type uncomplicated hepatitis NAFLD, what are the conditions that produce post-necrotic type of enzyme elevation, that is alcoholic hepatitis and cirrhosis. These are the 2 things that you need to know. Okay, so we have discussed about AST and ALT in a great depth and detail. Now we need to understand about markers of cholestasis as well. So what are the markers of cholestasis? We have number 1, your alkaline phosphatase, which is very important. Alkaline phosphatase is a quite non-specific enzyme. We know that compared to GGT. As far as alkaline phosphatase levels are concerned, the usual levels are 40 to 120. Anything more than 120, we are going to really call it as a elevated alkaline phosphatase. But again, the pattern is too important. So it's a very non-specific enzyme, to be precise. Why it's non-specific enzyme? Because apart from being in the biliary radicals, it's also present in intestine, which is called as an intestinal alkaline phosphatase. Then we have it in the germ cells called as germ cell alkaline phosphatase. Then it is present in placenta called as placental alkaline phosphatase. I think you would have studied in OG. The placental alkaline phosphatase is one of the markers of the congenital disorders that we use. Then we have something in some other organs, like for example, we have in the liver that's called a liver specific alkaline phosphatase. Then we have in the bone that's called a bone specific alkaline phosphatase. Then we have in the kidneys that's called a kidney specific alkaline phosphatase. So we have alkaline phosphatase in different areas. So it's quite non-specific. So whenever the patient is having elevated alkaline phosphatase, suppose in exam if they ask what are the conditions where you can have a elevated alkaline phosphatase, so it's very easy to tell what are the conditions where you have elevated alkaline phosphatase. Typically in the biliary pathology, any evidence of cholestasis or any biliary pathology, extrahepatic or intrahepatic, your alkaline phosphatase may be elevated. But remember, usually in biliary pathology, your alkaline phosphatase will be more than 2 times the upper limit of normal. Similarly, it can happen in hepatocellular disease also, because whenever the liver cell is injured, there will be some element of cholestasis will be there. But usually, typically here, it will be less than 2 times the upper limit of normal. So in both these situations, it can be elevated, but biliary pathology is very important. The same applies here also. If it's a hepatocellular injury, your alkaline phosphatase elevation, your OTPT elevation typically will be more than 3 times the upper limit of normal. If it's a true biliary injury, your AST-ALT elevation will be less than 3 times the upper limit of normal. Similarly, if it's a true cholestasis, your ALT will be elevated more than 2 times the upper limit of normal. If it's hepatocellular disease purely, there is no associated biliary pathology, then your LP can be elevated, but it will be less than 2 times the upper limit of normal. So that's why the pattern analysis is very important. It's not like AST-ALT is only for hepatocellular and ALP is only for biliary pathology. So the pattern is very important, which I'll be discussing in some time. Apart from this, you can get alkaline phosphatase elevation in some extrahepatic disease as well. Extrahepatic disease or extrahepatic source of ALP can be there. The physiological sources include pregnancy and children are very important because in pregnancy it comes from the placenta. In children it comes from the bone because of the high bone turnover. So this physiological cause. Physiologically in pregnancy and children you can have a elevated alkaline phosphatase. In pregnancy, especially in the third trimester, where the placenta is highly active, that is the time your ALP starts getting elevated. First and second trimester usually ALP may not be elevated that much. Third trimester is the place where your ALP may be seriously elevated. And any condition that produces high bone turnover. So which means here the alkaline phosphatase is coming from the bone, not from the liver. So in this situation, first I can talk about children also. So once again, I can tell you because in children also it is due to high bone turnover only. Or I can tell conditions which increase the bone turnover like hyperparathyroidism, especially a primary hyperparathyroidism. Then it can happen in patients with Paget's disease. It can happen in patients who's having bone metastasis. So typically, if you ask where in the bone it is coming from, it is typically coming from osteoblasts, not from osteoblasts. So anytime when the osteoblastic activity is high, in fact, alkaline phosphatase is a marker of osteoblastic activity, isn't it? So anytime when the alkaline phosphatase levels are high, it can come from the high bone turnover as well. So that's what you need to think about. So whenever there's high bone turnover, think about a elevated alkaline phosphatase as well. But remember, there is a condition where there is pure activation of osteoclasts like multiple myeloma, where alkaline phosphatase levels will be completely normal in multiple myeloma, because here it's osteoclastic activity causing bone lysis. So bone lysis alone without bone formation will not result in elevated ALP. So that is something you need to know about. As far as the half-life of alkaline phosphatase is concerned, we know the normal value, but as far as the T-half of alkaline phosphatase is concerned, it's approximately around 72 hours, which is again very important to know. And there are some situations where you might have a reduced alkaline phosphatase as well. So usually in exam, this is not very important, but if they ask you what are the conditions which produce reduced alkaline phosphatase, as far as I know, the only clinically relevant point where you have a reduced alkaline phosphatase is Wilson's disease. Wilson disease. This is the only clinically relevant point. When I'm talking about Wilson disease, I'll talk about that. So this is the only clinically relevant area where I can talk about a reduced alkaline phosphatase. Apart from that, I don't really think any other condition really matters. But there are some conditions where you can have a reduced alkaline phosphatase like hypothyroidism. Probably it can happen in zinc deficiency. Then it can happen in conditions like pernicious anemia. Or probably there is a condition, congenital condition, where there is congenital absence of alkaline phosphatase in the body, that is called as hypophosphatasia. Hypophosphatasia is basically an autosomal recessive disorder. It's due to autosomal recessive inheritance. It's a congenital disorder where you will not be able to produce alkaline phosphatase in the first place. It's typically going to affect the bone rather than the liver. But nevertheless, these are the conditions where you can have a reduced alkaline phosphatase. There is nothing like a reduced ALP and ALT usually in reality. But reduced AST and ALT is not there in reality. But reduced alkaline phosphatase may be an exam question. In that, I believe the most important is going to be the Wilson disease. Because we see something called a ALP by bilirubin ratio in Wilson disease. So that is based on the concept that in Wilson disease there will be a very low alkaline phosphatase. So that's why this is very important. And I've seen some 1 or 2 Wilson disease patients where alkaline phosphatase levels are only 5, 6, like extremely low alkaline phosphatase. So sometimes undetectable alkaline phosphatase. The lab will give alkaline phosphatase levels of less than 10. So we have seen these kind of cases as well. But 1 or 2 is what I have seen. But nevertheless, that's very important to know. Wilson disease have very low alkaline phosphatase. Second one is something called as a GGT. That's called a gamma glutamyl transferase, GGT. That is the second marker of cholestasis. The normal value is 10 to 60, but it can vary according 10 to 60. But it can vary according to the labs. Remember, this is an enzyme that is membrane bound in the biliary radicals, and it is very important for glutathione metabolism and especially amino acid transport. So this is an enzyme that can be induced as well by various drugs. That's why there are some drugs which can actually increase the level of GGT in the like body, especially in the biliary radicals, especially one drug called alcohol. So that is a strong inducer of GGT. So that's why it's one of the markers of alcohol abuse, which we'll be talking about. Remember, compared to alkaline phosphatase, this is more specific and is one of the most sensitive markers for cholestasis, for biliary disease. So if you want to talk about a biliary disease, so this marker is considered to be extremely sensitive, and it's quite specific also. It's not like only sensitive, it is actually quite specific, unlike your alkaline phosphatase. So whenever the patient is having a elevated GGT, there are quite a few causes. Usually elevated GGT is due to a biliary disease, but like how I told you previously, it can happen in hepatocellular disease also. But the amount of elevation in biliary disease will be much higher compared to the amount of elevation that is present in true hepatocellular disease only. And apart from these two causes, you have many other conditions where you can have elevated alkaline phosphatase, GGT, because I told you GGT is something that can be induced by some drugs. It's an inducible enzyme. So that is why alcohol is a very important drug that induces GGT. Remember, typically in alcohol abuse, please note the word alcohol abuse. I'm not talking about an alcoholic hepatitis. Alcoholic hepatitis is different, and we're going to diagnose alcoholic hepatitis in a extremely different way. We're talking about an alcohol abuse here. Most of the times when previously, not now, currently, like drunken driving easily identified by your the routine direct measurements in the first place. The breath test is something which is used, but previously, like maybe a couple of decades back, they used to measure alkaline phosphatase levels to submit the documents in court that the patient has consumed alcohol. GGT levels. So GGT levels alone are isolatedly elevated. Only GGT levels are elevated. Then we can even talk about an alcohol abuse in the court itself during one point of time. So right now we don't do that. But anyways, GGT is a very important marker of alcohol abuse, but not alcohol hepatitis. It can happen in patients who are taking phenytoin, because phenytoin is another enzyme that is an inducing enzyme. Because of enzyme induction, phenytoin can result in elevated GGT. There are very few other causes like diabetes and renal failure, CKD patients who can have elevated GGT. But nevertheless, I feel the most important will be the alcohol abuse. That is what is going to be asked in exams. Suppose if you have an isolated elevation of GGT without alkaline phosphatase elevation, think about alcohol abuse in reality. So that's what they're going to ask in exams. These are the markers of cholestasis. So now we have a variety of enzymes which we have described as liver function tests. But remember, from this we have to identify the patterns, which is very important. Once again, so if the AST and ALT is elevated, I'm not talking AST by ALT, AST and ALT. So to avoid confusion, let me remove that. AST and ALT are elevated more than 3 times the upper limit of normal. ALP can be elevated or not, doesn't matter. ALP can be optionally elevated, but if it's less than 2 times the upper limit of normal, typically this goes towards a hepatocellular injury. This is called as a hepatocellular pattern. Suppose if AST and ALT are elevated, but it is less than 3 times the upper limit of normal, and if ALP is elevated but more than 2 times the upper limit of normal, so this is typically going towards a biliary disease, or I can call it as a cholestatic pattern. So this is the final nutshell that you need to know. Suppose the patient is having AST ALT elevation more than 3 times the upper limit of normal, but ALP is elevated but less than 2 times the upper limit of normal, or AST ALT elevated less than 3 times the upper limit of normal, but ALP elevation more than 2 times the upper limit of normal, we call it as a cholestatic pattern. Remember, when I talk about AST and ALT, it's not like both should be elevated. Even any one is elevated to more than 3 times the upper limit of normal, you can call that the patient is having a hepatocellular pattern of injury. So these are the two patterns that you need to know, because there are a lot of diseases that have hepatocellular pattern and a lot of disease that come with the cholestatic pattern. But please understand, usually the space occupying lesion in the liver, like metastasis and hepatocellular cancer, typically come with a cholestatic pattern rather than a hepatocellular pattern. And there is countless number of overlaps are there between them. Like for example, many patients may have some overlap between them. They can have same hepatocellular pattern as well as a cholestatic pattern. Both can be there in the same patient. So there are countless number of overlaps are there in certain diseases, but we don't want to know all those things in exams. We just need to know what is the pattern to make a diagnosis in reality. That's all. This is the final take home point. And next thing is synthetic markers. The most important synthetic marker is albumin. Remember, albumin is something that is exclusively produced in the liver. It is not produced by any other cell type or any other organ in the body. At the same time, albumin is the predominant protein. We know that it contributes to 60% of the total protein that is circulating in the blood, the plasma. At the same time, albumin is important for many functions. It does that function of maintaining the colloidal osmotic pressure, which actually makes the fluid stay within the vascular compartment. So because it exerts something called a colloidal oncotic pressure. At the same time, it is a transport protein for a variety of enzymes and a variety of other proteins, whether variety of other hormones. But from liver perspective, albumin is something that also carries the unconjugated bilirubin. That's the most important part. Even though it carries it is a transport protein for a variety of hormones, enzymes, and so many things in the blood. But albumin is extremely important from liver's perspective because it carries unconjugated bilirubin. So that's very important. And similarly, the half-life of albumin is something we know already. It is approximately 3 weeks, that is 21 days. That's the half-life of albumin. So that is why serum albumin decline means it takes quite some time. So any decline in serum albumin means the situation is happening a little chronically, which means it's not acute. So which means it takes almost 2 months for albumin to come down. So during that time frame, it's okay to call that disease as a chronic disease. So usually in acute disorders, albumin will not decrease, but in chronic disorders, usually albumin will decrease. But there is some exceptions to the rule. For example, patients who are having redistribution type of hypoalbuminemia, which happens in cirrhosis and heart failure, there can be an acute decline in the albumin. So let us see that. So albumin decline can happen. Suppose if they ask you what are the conditions that have low albumin can happen in patients who are having reduced synthesis, or patients who are having increased loss, or there is a phenomenon called internal redistribution where albumin goes out of the vascular compartment and stays maybe in the interstitial area. So because of that, albumin levels are low in the blood. So reduced synthesis typically happens in the setting of a liver disease. This is the classic cause. But apart from that, it can happen in severe malnutrition. But even though we don't really encounter these kind of cases in reality, but India is a poverty-stricken country, so definitely we need to think about, especially when you're working in a low resource settings, about this malnutrition related cause of low albumin as well. But in reality, in exams anywhere in the world, whenever we talk about a low synthesis and low albumin, it's always about a liver disease. It's one of the important synthetic markers of the liver. And increased loss, liver is producing okay, but loss is there. There are two areas where you can lose. One is on the kidneys, that is called as a nephrotic syndrome, which is very important reality, and which is not that important reality is the protein losing enteropathy. So it can be lost in the GI route also. That is called as protein losing enteropathies. So there are many protein losing enteropathies. If there is time, we'll discuss about that as well, where you can have loss of albumin from the body. At the same time, as I told you, as internal redistribution, there are two things which cause internal redistribution. One is called sepsis, and second is a heart failure. So these are two conditions where you can have a low albumin. But one important point is usually these conditions, only if they are chronic, they can produce low albumin. Usually in acute situations, usually don't get a low albumin. So if it's an acute hepatitis or a chronic hepatitis, only in chronic hepatitis or a chronic liver disease, you're going to have a low albumin, not in acute liver disease. Acute liver disease, generally albumin tends to be okay only. And only in chronic liver disease or chronic hepatitis, your albumin levels are going to be low. But in these two settings, albumin can be low even in acute settings. That is because of internal redistribution. Internal redistribution does not mean that your things should be chronic. In sepsis and CHF, there can be an acute reduction in the albumin. That is the only condition where you can have acute reduction in the albumin. Apart from that, most of the conditions you'll have a chronic reduction in the albumin only. But any other chronic disease, not only this, plus any other chronic disease, chronic inflammatory disease, can result in the low albumin. That is because albumin is a negative acute phase reactant. Because it's a negative acute phase reactant, any chronic inflammatory disease like rheumatoid arthritis or any other chronic condition also can result in low albumin in the body. So fine. So this is all about albumin. Then we have the PTANR. So what are the conditions where PTANR is important? What are the conditions where PTANR will be elevated? And what is the significance of that? So what are the conditions that increase the PTANR? Because whenever PTANR is high, I can assume that the vitamin K dependent clotting factors are the ones that are problematic, and they are either not synthesized or something wrong is happening in vitamin K dependent clotting factors. So increased PTANR can be due to reduced synthesis of clotting factors, or it can be due to increased consumption of clotting factors. Increased consumption typically happens in the setting of a disseminated intravascular coagulation. We know that that's a usual cause, where you'll have elevated APDT also, where you'll have low fibrinogen content in the blood. At the same time, D-dimer levels will be elevated. So there are a lot of other pointers towards DIC, so we not worry about that. The patient will be in sepsis or some background cause will be there for DIC. So we know that. So DIC we have discussed about, already in detail in the previous sections itself. So increased consumption. Second is reduced synthesis. Reduced synthesis can happen in liver disease, where it is extremely important, or it can happen in the setting of a vitamin K deficiency. Vitamin K deficiency. So if you want to know some of the causes of vitamin K deficiency, usually in exam, vitamin K deficiency will happen in the setting of a warfarin use very commonly. I mean, warfarin use typically is not called as a vitamin K deficiency. It's like inhibition of vitamin K dependent clotting factors. So it's not a true deficiency. True deficiency can happen in the setting of malnutrition, which is again extremely rare, or it can happen in the setting of a malabsorption, which is actually quite common, especially in fat malabsorption, especially when the patient is having a celiac disease or a ileal disease, like Crohn's disease, or probably patient is having some pancreatic disease. So in that setting, whenever the patient is having a fat malabsorption, then the patient cannot absorb fat. They cannot also absorb this fat soluble vitamins like A, D, E, K. So they might develop a vitamin K deficiency. And this is very true in cholestatic disease. In reality, so vitamin K deficiency is extremely important in cholestatic disease. So especially in severe cholestasis, what happens is, because this bile is very important for absorbing this vitamin K and fat soluble vitamins, one of the important markers of cholestasis, even without liver failure, is that coagulopathy. So which means even without liver failure, if a patient is having a severe cholestasis, they can have a coagulopathy. That is ecchymosis, this kind of blood leaking, bleeding, especially mucosal bleeding. And all these things can happen even without liver failure. So this is one situation where you need to know, where even without liver failure, where you can get a coagulopathy, that is in cholestasis. That is because of loss of bile preventing the absorption of vitamin K, resulting in elevated PTANR, and thereby causing problems in coagulation as well. And apart from that, it can happen in the setting of broad spectrum antibiotics, which is quite important. Broad spectrum antibiotics is quite important as well. So because the bacteria and the intestine are very important in producing vitamin K, especially the active forms. So if you give a broad spectrum antibiotics and wipe off this bacteria, then you might not be able to produce adequate amount of vitamin K. So your vitamin K deficiency can peep in. So especially we have seen this in many ICU patients. Like for example, a patient, I used to get a call over very routinely most of the times. After surgery, they usually, I do have a patient with cholangitis. I did had a patient with cholangitis who was treated with meropenem, and later on this patient went for a cholecystectomy because they thought it's a biliary disease, the stone that caused the CBD obstruction cholangitis. So they went for a cholecystectomy. After cholecystectomy, everything resolved. The bilirubin got okay, the enzymes got okay, but the only one thing that was very concerning is elevated PTANR. So this is what the very concerning. Then the patient was absolutely okay, free of sepsis. Initially, the surgeon thought it should be due to sepsis, and she was continuing meropenem because in sepsis there will be DIC. So she thought it's a factor of DIC, but she didn't test the D-dimer though. But nevertheless, they thought it to be sepsis, and they are continuing meropenem for a long time. But later on, when there was a situation where we felt it is not due to sepsis, it is due to meropenem, and once we stop the meropenem, this PTANR become completely normal. So many of the times, the continuous use of broad spectrum antibiotics can also result in elevated PTANR. That is due to destruction of the bacteria in the intestine that are very productive in producing this vitamin K. And at the same time, you can get in patients who are newborn, that is called as hemorrhagic disease of the newborn. Everyone would have studied about that. That's why prophylactically most of the newborns will receive vitamin K injections. And number 3, of course, anticoagulants like warfarin can act as a antagonist of this vitamin K dependent clotting factor synthesis, and that's why you can result in a elevated PTANR. So these are the causes where you can get elevated PTANR, but in our context, the liver disease is going to be the most important. So that's what we need to know. That's going to be the most important. Cool. So now we have studied about all these things. So it's enough. So now we'll move on to the bilirubin handling by the liver, which is quite important as well. There are so many things in bilirubin handling, so many minute things are there, but I don't think it's really that important to know. There are a few things which you can break down and we can really see what's going to happen. So first, as far as the bilirubin is concerned, so how it is produced and how it is basically handled is what is going, is what is the most important aspect here. So how we are going to break it down into different steps of how it is going to handle. The first thing is the heme that is actually broken down by the reticular endothelial system. That is the one that is going to form the bilirubin. So we can talk that as the first step. Maybe we can talk about a macrophage that is actually taking the RBC, and they're going to break down into heme and globin, and heme will be converted to something called a bilirubin. Heme is the one that is converted to something called a bilirubin first. Clear? So initially, they were going to produce that biliverdin, so then they will produce bilirubin. But I don't want to go into that small kinds of intricate details where they're going to produce bilirubin first. And this bilirubin initially will be unconjugated type of bilirubin. So because it's unconjugated type of bilirubin, it will be usually attached with albumin, and they will enter the area called liver. So where in the liver, it will be handled by the hepatocytes. Once they are handled by the hepatocytes, they will be moving out of the liver as conjugated bilirubin. The same bilirubin will become a conjugated bilirubin. And this conjugated bilirubin is going to come through bile first. And in the bile, they're going to come to the area called intestine. Because the bile is going to flow into the intestine. In the intestine, they're going to actually get excreted down. But before that, they will be acted upon by the intestinal bacteria. So this intestinal bacteria is going to convert this bilirubin that is coming through the bile into something called a urobilinogen. A portion of the bilirubin is actually converted to something called urobilinogen. This urobilinogen is further split into two things. One is called as a stercobilinogen, and second is called stercobilin. So first, from the urobilinogen, you are going to form stercobilinogen. That will be excreted as something called stercobilin, and that is the one that is going to give rise to the characteristic yellow color of the stools that we see. So that is the reason. That is why whenever there is cholestasis, when you block the bile from reaching the intestine, if there is a cholestasis, you can get a pale colored stool. So we have studied about that. So that is because of the loss of conjugated bilirubin to reach the intestine, which cannot be converted to stercobilinogen and further stercobilin. So that's where the problem is. So this urobilinogen, what happens is, largely will be excreted in the urine, in the stools itself, but some amount of urobilinogen is reabsorbed, and it will re-enter the liver, where this circulation will keep on continuing. This is called an enterohepatic circulation. And some of the urobilinogen is actually entering the kidneys. Some of the urobilinogen is actually entering the kidneys, where the kidneys are going to experience, excrete this urobilinogen, which will be further excreted, converted to something called a urobilin. This is the one that gives the straw yellow color of the urine. Typical straw yellow color of the urine. This is a simplified steps that happens in bilirubin handling. But the most important thing to note here is the enterohepatic circulation that happens. So this is what we refer to as the enterohepatic circulation. That things which I have shared in yellow is what we refer to as something called as enterohepatic circulation, which is actually quite important to know. Why? Because whenever you lose this enterohepatic circulation, they'll ask you what are the conditions that has loss of this enterohepatic circulation. The most important condition where you lose the enterohepatic circulation is severe cholestasis. In patients who are having severe cholestasis, you will not have this enterohepatic circulation. If you don't have this enterohepatic circulation, you cannot produce stercobilin. So usually it will typically result in this pale colored stools, number one. At the same time, if you don't have this enterohepatic circulation, you cannot get the urobilinogen into the kidneys as well. The urobilinogen in the urine will be absent. These are all the signs of cholestasis. Whenever you have a cholestasis, you're going to have a pale colored stools. At the same time, your urine urobilinogen will be absent. I mean, I'm not talking about a conjugated bilirubin. Nevertheless, I'm talking about the urine urobilinogen. Remember, urine urobilinogen is largely different from conjugated bilirubin. That's very, very important. So in a cholestasis, in a severe cholestasis, especially if the bile flow is not proper, you will lose the intrahepatic circulation. So where you're going to get a pale stool and an absent urinary urobilinogen. Very, very important point. We'll be discussing about that in some time. So this is a simple bilirubin handling in a way, but how the liver handles is what something we need to see. So we need to see that particular thing in detail now. So how the liver is going to handle the bilirubin load. So how the hepatocyte is going to handle the bilirubin load. Let us draw a hepatocyte. So let me assume this is the bile canaliculi. Okay, there are two adjacent hepatocytes, and this is the bile canaliculi we are talking about. So as far as the hepatocytes are concerned, how the bilirubin enters the liver is a mystery. We don't really know how the bilirubin really enters the mystery, even though there are so many other proteins that are implicated, like ligandin complex. But nevertheless, let us assume this is the hepatocyte, and this is the blood area. This is the blood, where we know that bilirubin is basically bound to something called albumin. So this is an unconjugated bilirubin, by the way, that is coming from the reticuloendothelial system. So this bilirubin is going to enter the hepatocyte through a complex called as ligandin. We believe that it's due to ligandin, but there are so many other theories are there. But nevertheless, so once it enters, the albumin will be going off. Albumin will not enter the liver. But on the other hand, the bilirubin is the only thing that is going to enter the liver. So how they're going to enter and what is this compound, nobody knows. What is this one? There is a lot of speculations are there, but we believe it is something called as a ligandin. There's a protein called ligandin, but nevertheless, this is the only candidate that is promising right now, but we don't really understand how the bilirubin enters. Is there any really a transport risk there or not? They believe that bilirubin comes along with the ligandin complex inside by taking that also inside, but we really don't know that. So let me keep it bilirubin and let us keep it simple. And this bilirubin now is in the cytosol. So let us assume this is the cytosolic area. And it starts entering the endoplasmic reticulum. Let us assume this is the endoplasmic reticulum area. And you have again a cytosolic area. It comes out again in the cytosol. So while entering into the endoplasmic reticulum, there is an enzyme that is called as, in the endoplasmic reticulum, you have an enzyme called UGT1A1. UGT1A1 enzyme is there. So where it is going to convert this bilirubin into something called a bilirubin glucuronide. Remember, usually there will be a formation of diglucuronides. It's not a monoglucuronide. So initially it will form a glucuronide. And once again, the same enzyme will be present in the other side of the endoplasmic reticulum as well. Again, this is the same UGT1A1 only. That is UDP glucuronyl transferase enzyme. So which is going to convert this bilirubin into something called a bilirubin diglucuronide. Initially, it comes as a monoglucuronide. Then, while exiting into the cytosol again, they will become something called a diglucuronide. And this bilirubin diglucuronide is the one that is going to enter the bile canaculus, which I can actually paint it in green to understand. So this is a bile canalicus we are talking about. And entering into the bile canalicus needs a very important transporter. We know that what is that transporter that is important to enter the bile canalicus, that is called as MRP2, which is an ATP dependent process where it consumes one ATP, that is called as multi-drug resistant protein 2, otherwise referred to as by another name called as CMOT. CMOT, that's called a canalicular multi-specific organic anion transporter. Canalicular multi-specific organic anion transporter. Simply we can call it as MRP2. That is called as multi-drug resistant protein. That's all. So, and again, like the bilirubin will be excreted into the bile. So through the bile canalicus, they're going to come into the bile. So in the bile, you will typically have a conjugated bilirubin. Conjugated bilirubin. Typically, you have this diglucuronides. That is very classic, but nevertheless, it will be a conjugated bilirubin. And there will be some amount of conjugated bilirubin in the blood as well. Why? Because of the intrahepatic circulation. Because you have this intrahepatic circulation intact, and at the same time, some of the conjugated bilirubin, because the conjugated bilirubin is water soluble, it can easily enter the blood as well. So it is water soluble. And the conjugate bilirubin can be easily excreted in the urine also. So conjugate bilirubin is not a problem at all. So it can be excreted through the bile. It can be easily excreted through the urine as well, and it can be easily mixing in the blood as well. So unconjugate bilirubin is the problem because it's going to cause a lot of oxidative effects also. But conjugate bilirubin usually is most of the time harmless because it can easily dissolve in the blood and it can be excreted through urine or probably bile or through some other areas as well. Doesn't matter. So these are the typical steps that happen. In that, most of the things will not be asked in exam. Don't worry about that. So because this is not at all relevant for your exams. So maybe the disease that are associated with this bilirubin handling is what they're going to ask. So first of all, we need to know what do you mean by a jaundice. I mean, to be honest, then you can ask me why you told all these things, but to understand only I told, but none of this will be a question in your exam. None of these things. Nothing will be asked in exams. Please be very clear about that. So just to know what do you mean by monoglucuronide, what do you mean by diglucuronide, what is the transporter that is important, and how it is getting excreted, and what do you mean by unconjugated, what do you mean by conjugated bilirubin, and what is the complex that is important, that is lycantin complex to enter into the liver cell. So just for your understanding, nothing else. So jaundice has different definitions. So jaundice does not really mean that you're having an icterus. So icterus and jaundice are basically different terminologies. Icterus is something which is a clinical diagnosis. Jaundice is something, again, that is quite different. So any elevation of bilirubin is what we refer to as jaundice. So, I mean, in reality, but whether jaundice associated with icterus or not is a question. So, for example, when you get an icterus is by approximately around when a serum bilirubin goes by approximately 3 milligrams per deciliter. Anything if it becomes more than 3 milligrams per deciliter, this is the Harrison definition basically. But there are some Oxford kind of textbooks which give 2.5 as the diagnosis. But whenever the serum bilirubin exceeds 3 milligrams per deciliter, we typically call it as a jaundice. And this is the time where you get the icterus as well. What do you mean by icterus? Icterus typically happens in the sclera. That is, yellowish discoloration of the sclera is what we refer to as icterus. But yellowish discoloration of other parts of the mucous membrane can happen at bilirubin of more than 4 to 5 milligrams per deciliter. So this is what is going to happen in the sclera. So you got the scleral icterus. When the bilirubin exceeds 4 to 5 milligrams per deciliter, then at this situation you can get mucous membrane discolorations as well. Mucous membrane discoloration as well. Clear? Typically, there are two types of hyperbilirubinemia. So whenever you have a jaundice or whenever you have a icterus, means there is a hyperbilirubinemia. Increased bilirubin is what we refer to as jaundice. So this hyperbilirubinemia can be either conjugated or unconjugated. So there are unconjugated hyperbilirubinemia as well as conjugated hyperbilirubinemia. So we need to know the cause of both. So what are the cause of unconjugated? What are the cause of conjugated hyperbilirubinemia? First, when I'm talking about unconjugated hyperbilirubinemia, unconjugated hyperbilirubinemia can be due to overproduction, number one, or unconjugated hyperbilirubinemia can be due to reduced uptake of bilirubin by the hepatocytes, or it can be due to defective conjugation. If you go back to the image that you have been discussing till now, so probably they are producing too much of bilirubin. I told you the RBCs are destroyed extraordinarily in excess amounts. So because of that, there are too much bilirubin that is produced. So because of that, it spills over. Liver cannot handle that much high bilirubin. So because of that, you might get a unconjugated hyperbilirubinemia. Or next thing, what you can have is the liver is actually taking up lesser bilirubin. So there is, unconjugated bilirubin coming to the liver, but the liver is not taking up sufficient amount of bilirubin. That is number 2. And number 3 is a place where there is a defective conjugation. So which means the bilirubin is there, it is coming into the liver as well, but the problem is some of the enzymes like UGT1A1 is defective because of the conjugation is defective. So you'll have an increased unconjugated hyperbilirubinemia. So cause could be anything of the 3 which I've told you. As far as overproduction is concerned, so typically the number 1 cause is hemolysis, which can happen in the periphery, or it can be due to ineffective erythropoiesis. So there are 2 different causes of hemolysis. One is probably, it could be ineffective erythropoiesis where the cells are destroyed in the bone marrow itself, or there could be peripheral hemolysis. Hemolysis typically means it's peripheral only. Ineffective erythropoiesis should not be really called as hemolysis, but it can happen. So, or I can write separately also. Ineffective erythropoiesis. Both are due to red blood cell destruction, which can increase the heme production, increase the bilirubin production, which cannot be handled by the liver, that a high load of unconjugated bilirubin. Or reduced uptake typically happens in conditions that produce a portosystemic shunt. Portosystemic shunt. So what are the conditions that produces portosystemic shunt? I believe the number one condition that produces portosystemic shunt is cirrhosis. Cirrhosis is a classic example of a condition, or any liver failure produces a portosystemic shunt. So what do you mean by portosystemic shunt? So it's understandable very simply. So what happens in the liver is very simple. So in the liver, you have the hepatic artery and the portal vein. You have the hepatic artery and the portal vein. Both this hepatic artery and the portal vein are going to pour into a common area called hepatic sinusoids. You know that. So this is a common hepatic sinusoid. So in the sinusoids only, you have this array of hepatocytes. You have hepatocytes that are arranged in the sinusoids like this. So these sinusoids finally take their blood and flow into some area called as hepatic vein over here. So I can write hepatic vein. So this hepatic vein is the one that is going to reach the IVC. And they are going to enter the heart, and this is what we refer to as a systemic circulation, systemic side. And this portal blood is basically coming from the liver, we know that. So this is the portal blood that is coming from the, coming from the intestine, coming from the mesenteric circulation, carrying all the nutrients as well as some toxic products from the bacteria like ammonia. So from the mesenteric circulation, like inferior mesenteric artery, superior mesenteric artery, celiac axis. So this is the blood that is coming from the mesenteric circulation, which is entering the portal vein. I mean, it's not artery basically. It's like superior mesenteric vein. Probably we can think about splenic vein. So SMA and splenic vein is something that combines together to produce the portal vein. We know that. So this is the portal circulation. So as the blood enters the sinusoids, and if it is moving towards the hepatic vein, there is so many processes that is happening in between. Like for example, there are certain waste products that will be taken up by the liver and will be filtered. And at the same time, there are some good things like proteins that are also given back into the sinusoidal blood. And this process is going to happen throughout the sinusoidal circulation. So they filter that waste products like ammonia and all, and they're going to give rise to some good things like synthesis of proteins, coagulation factors. All these things will be poured into the sinusoidal blood. So once the blood reaches this hepatic vein, it will be pure, devoid of toxins, and at the same time it will be rich in proteins and other coagulation factors and a lot of other things that we see. So what do you mean by a portosystemic shunt? Whenever there is a liver cell failure, for example, if these liver cells are non-functional, so if there is a liver cell failure, what happens? This kind of exchange is not possible anymore. And what's going to happen is, suppose if you have an unconjugated bilirubin, that is one product that has to be actually conjugated by the liver and it should be extracted in the bile, and they just go just like that into the hepatic vein, and the level of unconjugated bilirubin is going to rise in a patient who's having a liver cell failure or probably a cirrhosis. So this kind of portal blood that directly reaching the hepatic veins and the systemic circulation without getting purified or filtered by the liver cells is what we refer to as a portosystemic shunt. So this is a physiological portosystemic shunt. We have some anatomical portosystemic shunts also, which we'll be discussing later on. But this is an example of a physiological portosystemic shunt. So what do you mean by physiological portosystemic shunt? It's just the portal venous blood without getting filtered because of liver cell disease and liver cell failure, without getting filtered. It is just entering the systemic circulation. So that is what we refer to as the physiological portosystemic shunt. And this physiological portosystemic shunt is the main reason for so many problems like elevation of bilirubin in cirrhosis patients and liver failure patients, and elevation of ammonia levels, getting encephalopathy, coagulopathy. So the classic signs of liver cell failure like encephalopathy and coagulopathy is also due to this physiological portosystemic shunt. At the same time, elevation of unconjugated bilirubin is also due to this physiological portosystemic shunt only. So these are the reasons which causes this elevation of unconjugated bilirubin in cirrhosis patients as well. And you know what is the space that is present between this sinusoids and the liver cell? And we know this space is what we refer to as a space of Dis. Everyone knows that. And if somebody asks you what are the constituents of space of disk, what is the most important constituent of space of disk? Can anyone tell? Space of disk, most important constituent. What is the most important cell? Yes, stellate cell. Stellate cell is the most important cell that is present in the space of disk. Yeah, ito cells are there, but as far as my clinical understanding is concerned, the stellate cells are the most important. So because that is the one that actually maintains the integrity of the the sinusoidal endothelium. So the sinusoidal endothelium's integrity is actually maintained by the stellate cells only, and stellate cells are important for a variety of other reasons as well. So, but this is a simple understanding of how your portostemic shunts work, and how in a liver cell failure there will be physiological portostemic shunts, even though there is no anatomical portostemic shunt. But this is like a physiological shunt where you're directly shunting the portal blood to the systemic blood without getting any sort of toxin removal or any protein production that is released into this circulation. That's why I told you cirrhosis is one important cause where you can get portostemic shunts. And second thing, there are a lot of drugs that can reduce the uptake of bilirubin by these cells. What are the drugs that can reduce the uptake? For example, there are some drugs like rifampicin that can reduce the uptake, can raise the unconjugated bilirubin. One of the uricosuric agent like probenecid. Third, we have something called sulfonamides that can do this, that can raise the bilirubin. And penicillin drugs can do this, even though it's very, very rare, not very important. And some radio contrast agents can do this as well, but not that important, only experimentally, but theoretically not. These are things that are not very important in the first place. But the most important, clinical cause of a portostemic shunt causing reduced uptake, rising unconjugated bilirubin is your cirrhosis only. And similarly, hemolysis can cause unconjugated bilirubin rise, that is due to overproduction. Similarly, defective conjugation can happen due to some inherited causes as well as due to some acquired causes. Both these things can produce elevation of unconjugated bilirubin because of defective conjugation. Inherited, we know, that is Gilbert syndrome and Crigler-Najjar syndrome, which we'll be discussing in some time. Gilbert syndrome and Crigler-Najjar syndrome. And acquired causes, so many causes are there. For example, we have something called a breast milk jaundice. So because of breast milk, you will get unconjugated hyperbilirubinemia because there is a compound in the breast milk called as 3-alpha-20-beta pregnant diol. You have studied in pediatrics, isn't it? There is something called 3-alpha-20-beta pregnant diol. In certain selected children, this compound in the breast milk can cause defective conjugation because they inhibit the UDP glucuronidase transferase UGT1A1 enzyme, so that they can result in elevation of unconjugated bilirubin in the child. So that's called a breast milk jaundice. And you have hyperthyroidism. Hyperthyroidism can also inhibit the UGT1A1 enzyme. And patients who are having some problems like neonatal jaundice, at the same time, patients who are taking some drugs. So what are the examples of drugs that can cause defective conjugation? The most important, as far as I know, is atazanavir and indinavir. To be honest, atazanavir is more important for me because clinically, whenever I give atazanavir, majority of the patients develop severe jaundice. Like I've seen patients who are having bilirubin of 4, 6, even 10, up to 10 bilirubin I have seen, but it will be mostly, not mostly, always it will be unconjugated hyperbilirubinemia and the enzyme levels will be normal. So atazanavir is something, it's a very commonly used drug in clinical practice. It's HIV protease inhibitor, very commonly used in Indian population also, where many of the times after giving atazanavir, you will encounter jaundice, which most of the time it will be a very harmless jaundice. That's because only unconjugated bilirubin will rise, enzymes and all will be normal. There will be no liver cell injury or failure or anything. Just because of poor conjugation, your unconjugated bilirubin alone will rise. In adults, because the blood-brain barrier is very good, this rise in unconjugated bilirubin alone without any underlying liver problem will not cause any problem. So you can reassure these patients. And at the same time, you need to tell the patients before giving atazanavir that bilirubin might rise, because that's very worrisome sign. Patient will get jaundice after taking atazanavir. So they will, because in our population, whenever they get jaundice, they believe that their liver is failed and liver is gone. So you have to be very clear about that. So you have to instruct the patient beforehand itself, so that that you're going to get the jaundice and it is harmless and you can continue taking atazanavir despite getting the jaundice, no problem. And there are some other drugs that can cause this, like chloramphenicol can do that. Chloramphenicol can do that. And you can get with some aminoglycosides like gentamicin and some old drugs like novobiocin is there, but that's not really important. So we don't use novobiocin only, except for this drug is used for differentiating that staphylococcus and microbiology. Apart from that, novobiocin we don't really use that much. So clinically relevant drugs are atazanavir and chloramphenicol. In that, the most important, I would say, atazanavir is very important because that is the one drug that very commonly causes and almost always causes jaundice, and it's harmless and it's more clinically relevant in your practice. So these are the conditions that produces defective conjugation. Because of that, you will have a unconjugated hyperbilirubinemia. So there are some conditions which can cause conjugated hyperbilirubinemia also. So what are the conditions that produces conjugated hyperbilirubinemia? Conjugate hyperbilirubinemia. As far as conjugate hyperbilirubinemia is concerned, whenever you see this kind of condition, you first see the ALP levels, where the patient is having an increased ALP, which means the patient is having a cholestasis, and because of that, they're having conjugate hyperbilirubinemia. Whenever the patient is having a normal alkaline phosphatase, and if they're having elevation of conjugated bilirubin, usually this is due to canalicular defects. Canalicular defects means the liver function and all is okay, there is no problem. The patient is not able to excrete this bilirubin into the bile. That's all. So that is the only problem. So usually this canalicular defects will be mostly congenital. And there are two syndromes. Everyone knows that one is called as a Dubin-Johnson syndrome and second one is called as a Rotar syndrome. These are two syndromes that can cause elevated conjugate bilirubin, but rule is they should have a normal alkaline phosphatase, which means there should be normal liver enzymes. Most of the congenital defects of bilirubin handling will have normal liver enzymes. They won't have any problem at all. As far as cholestasis is concerned, so you can develop something called as an intrahepatic, you can have something called as an intrahepatic cholestasis, and you can have something called as an extrahepatic cholestasis. I'll tell you the approach in some time. So intrahepatic cholestasis can be due to obstructive type or non-obstructive type. Extrahepatic cholestasis is almost always obstructive only. So this can be due to cholelithiasis, or it can be due to some bile duct injury or bile duct stricture, which can happen after a laparoscopic cholecystectomy, or it can be due to cholangiocarcinoma, or it can be due to a periampullary cancer, especially the pancreatic head tumors, which are typically periampullary. And in the intrahepatic side, obstructive causes, number one is tumors of the liver, or I can write space occupying lesions of the liver. That is very important. As I told you multiple times, space occupying lesions in the liver typically produces a obstructive type of pattern. That is cholestatic type of pattern only. You know, the AST ALT can be elevated, and the AST will be more than ALT, but it typically produces obstructive kind of pattern. As far as non-obstructive is concerned, the most important exam is going to be the PBC, primary biliary cirrhosis. Then we have progressive familial intrahepatic cholestasis, that's called PFIC, progressive familial intrahepatic cholestasis. Then we have something called ICP, that is intrahepatic cholestasis of pregnancy. And there are some drugs that can produce this cholestasis, especially oral contraceptive pills. OCPs are very important. And apart from that, there are many other conditions, many other drugs like amoxicillin, clavulanic acid, dicloxolin, which I'll discuss in some time. A lot of drugs can produce non-obstructive type of cholestasis, but in exam, the clinically relevant thing is the primary biliary cirrhosis. So that is very, very important. So these are the conditions that produces conjugated hyperbilirubinemia, and these are the conditions that produces unconjugated hyperbilirubinemia. And I told you what do you mean by portal stomach shunt, and why liver cell failure is a type of a physiological portal stomach shunt. All these things you will be able to understand now. And if you want to tell the different types of jaundice, let us now put everything in a nutshell, because there are so many things which you have told, which you have discussed. It's very easy to get lost yourself, you know, like in the sense like you will be lost somewhere. So many things we have discussed, and where to put everything into perspective. That's what I want to tell first. How to approach a patient who's having a jaundice or probably having an abnormal LFT. How will you approach a patient who's having abnormal LFT? That's what you're going to see. I'm going to give a master chart here, so which will be very useful for your exams. So number one, so see the liver enzymes first. Whenever the patient is having an abnormal LFT, see the liver enzymes first. So if the patient is having elevated liver enzymes, elevated liver enzymes, or the patient is having a normal liver enzymes, but having an abnormal LFT. So whenever the patient is having an elevated liver enzyme or some abnormality in the liver enzyme, see what is the pattern. So we know whether it's a hepatocellular pattern, or if it's a cholestatic pattern. So we know what you mean by hepatocellular pattern again. If the AST and or ALT is elevated more than 3 times the upper limit of normal, ALP can be elevated or normal, doesn't matter, but it will be less than 2 times the upper limit of normal. So this is hepatocellular pattern. Cholestatic pattern, AST or ALT will be elevated, but less than 2 times the upper limit of normal. ALP definitely will be elevated here, and it will be more than 2 times the upper limit of normal. And write 3 here. So this is a typical cholestatic pattern. So whenever you have a hepatocellular pattern, so it's hepatocellular disease. So in this setting, to tell whether it is acute or chronic, I am going to use albumin. Of course, I need history also, but albumin is what I'm going to see. If albumin is normal, then likely I'll talk about an acute hepatitis. If albumin is low, I'm going to talk about a chronic hepatitis. Clear? As far as acute hepatitis is concerned, what are the investigations that you need to evaluate? So one is going to be the ultrasound. That's very important. Second is going to be the viral markers, because it could be an acute viral hepatitis. Third is going to be the ANA to rule out autoimmune hepatitis, because there are some types of autoimmune hepatitis which can come as acute hepatitis as well. And fourth thing, very rarely I need to do a ceruloplasmin. But more importantly, even before all these things, I need a good history. That's very, very important, because many times, don't forget these drugs. Drugs can be a very important cause of acute hepatitis as well. Many drugs can produce hepatitis. So including your tubercular drugs, which is extremely common in clinical practice, like pyrazinamide, rifampicin, INH. So many drugs can cause hepatitis. So history is very, very important. Especially the drug history in hepatology is, extremely important. If you miss that, like in any hepatology exam, you will not pass. So drug history is so important in exam. But as far as we know, there are very few common patterns in acute hepatitis that they're going to ask in exam. So let me tell you some important common patterns that you will get in exams. So pattern number 1, where AST and ALT, typically AST-ALT ratio will be less than 1. At the same time, AST-ALT usually in thousands. Usually will be more than 600, but whenever you see in thousands, so this pattern typically seen in exam, it's always acute viral hepatitis. That's all. Whenever you see AST-ALT ratio of less than 1, at the same time AST-ALT is in the range of thousands, think about an acute viral hepatitis. And number 2, it could be any drug, but very commonly in exam we need to know about this paracetamol poisoning. Or any drug poisoning, like your rat killer poisoning. So many things can cause that. And number 3, you can get an ischemic hepatitis. Usually any patient after a cardiac arrest or after a severe acute decompensation heart failure, if they come with AST-ALT in the range of thousands, we can talk about a ischemic hepatitis, very common. These are 3 conditions where you can develop this AST-ALT in the range of thousands. So this ischemic hepatitis is also referred to as something called as a shock liver. Clear? So this is what the thing is. And at the same time, there are some conditions where AST-ALT ratio can be more than 1. At the same time, plus your AST and or ALT can be in thousands once again. There are few conditions where AST and ALT can be more than 1, which means the values are more than 1, but AST-ALT will be in the thousands. Again, which means it will be more. Yeah, I'll come back to that. Septic hepatitis, it's not septic hepatitis. Siddharth is asking about septic hepatitis. It's not that. I'll come back to that in some time. So you're confusing something else. So AST-ALT ratio of more than 1, but AST-ALT in the thousands, but at least more than 400. But usually in the thousands. So this situation is where you get fulminant hepatitis or fulminant liver failure. You will get this kind of picture. It can be usually in reality, it can be due to anything, but in exam, usually it will be due to acute Wilson. You can suspect acute fulminant Wilson can present like this, and acute fulminant autoimmune hepatitis can present like this, usually. These are two conditions that in exams you need to suspect whenever AST/ALT is more than 1, but the AST/ALT are in the thousands. Third thing is the most important of all, AST/ALT ratio of more than 1 plus AST is elevated here, but AST is less than 400. AST value is less than 400. AST is more than ALT, doesn't matter, but AST is actually less than 400 here. So it's not that much elevated. AST is not that much elevated, but AST/ALT ratio more than 1. So typically, if I tell that word, you will easily find out. But AST/ALT ratio will be in the range of 2:1. 2:1, more than or equal to 2:1. So if I tell that, this is called a de-Ritis ratio. Everyone will tell that because this is something quite common. That is alcoholic hepatitis. Everyone knows that. Alcoholic hepatitis, typically the ratio will be more than or equal to 2, or called as 2:1 ratio. So this is what we refer to as a de-Ritis ratio. These are the 3 patterns that we need to know of acute hepatitis. Whenever you have an inflammatory pattern, typical inflammatory pattern, you will see in acute viral hepatitis, paracetamol poisoning, and ischemic hepatitis, where AST/ALT ratio will still be less than 1. If AST/ALT ratio becomes more than 1, but if you see a very high AST and ALT, like more than 400, usually in the thousands, you think about a severe fulminant hepatitis like Wilson disease or a acute fulminant AH. In reality, any fulminant hepatitis or very severe hepatitis can produce this kind of AST/ALT ratio of more than 1. If AST/ALT ratio is more than 1, but AST level is less than 400, at the same time, your AST/ALT ratio is typically in the range of more than 2:1. That is de-Ritis ratio. You think about an alcoholic hepatitis. Out of all these 3 things, this is the most important for exams. Alcoholic hepatitis, multiple times asked question. Similarly, in chronic viral hepatitis, I need to do a lot of evaluation. Like for example, I need to do an ultra. I mean, again, the history is something that's quite important. Even drugs can cause chronic hepatitis. So drugs are something that has to be ruled out at all the steps. So many drug can cause acute or chronic hepatitis, doesn't matter. So evaluation include, I need to do an ultrasound, I need to do viral markers for sure. I need to do ANA to rule out autoimmune hepatitis and other markers of ANA. I might be needing to do ceruloplasmin to rule out Wilson disease. These are rare causes. But apart from that, in selected patients, I can do ferritin and transferrin saturation because hemochromatosis can cause this hepatitis, but rare again in India. I don't see even a single case of hereditary hemochromatosis. And alpha antitrypsin deficiency, extremely rare situation. Most of the times, a very good history, ultrasound, viral markers, and ANA is more than enough. Most of the cases, this is sufficient. So very rare cases, you might be needing to do a ceruloplasmin, ferritin, transferrin saturation, or alpha antitrypsin deficiency. But remember, the pattern here is quite simple. The pattern here could be anything. The pattern is extremely simple here. So usually you will see AST and or ALT elevated, and it will be in the range of 50s and 100s usually. 50s and 100s. Very commonly you will see in the 50s and 100s. In the sense like you'll not be having that much elevation, like 90, 200, 300. So this is the thing you will get. So whenever you see this kind of pattern of 50s and 100s AST elevated, you think about a chronic hepatitis. It could be resolving acute hepatitis also, but in some particular timing, if you take it will be in 50s and 100s. But usually this pattern goes towards a chronic hepatitis only. It's not an acute hepatitis, and the evaluation is based on these things which I've already told you. And remember, even in this condition, your AST and usually in many of the situations, AST/ALT ratio will be less than 1 only. Majority of the situations, but please understand, whenever AST/ALT ratio becomes more than 1, with the same 50s and 100s AST/ALT more than 1, usually it is suggestive of patient is going for a cirrhosis. Whenever the patient enters a cirrhosis, your AST/ALT ratio will flip and it will become more than 1. That's an extremely important point once again to know. So usually a chronic hepatitis patient easily can go to a cirrhosis, and because of chronic inflammation injury that is happening, they'll move to cirrhosis. Whenever they move to cirrhosis, one of the most important markers of cirrhosis is this AST/ALT ratio becoming more than 1, where AST levels will be more than 1. Will be more than ALT. I'm not telling AST/ALT in cirrhosis will be in thousands or 500s. No, it doesn't matter, because the number of cells are not there. AST and ALT are markers of liver cell injury. So when in a cirrhosis patient, you won't have that much of cells to actually produce high amount of AST and ALT. So AST-ALT ratio will not be in thousands or 10,000s like what you see in acute hepatitis. It will be like 50, 60, but still that's very important. AST will become more than ALT in a chronic hepatitis patient is actually suggestive of cirrhosis. But many times, remember, you need to know in cirrhosis, the enzymes can be completely normal. This is something quite important that is bamboozling to many students. They think like, why in cirrhosis the enzyme should be normal? Because you don't have any liver cells to have produce these enzymes. So you have destroyed all the liver cells, the entire liver has gone for fibrosis, and this thing means where are the cells to produce this enzyme? So enzymes can be actually normal in a patient with cirrhosis. So cirrhosis does not mean that the enzyme should be elevated or anything else. Usually enzymes can be normal in a patient with a cirrhosis. And similarly, cirrhosis doesn't again mean the patient should have elevated bilirubin also. So cirrhosis a difficult diagnosis to make. It's like a shrunken liver. It's most often a pathological or at least a radiological diagnosis where you have to prove these nodules in the liver. Then only you can call it as a cirrhosis. Just by seeing a bilirubin or just by seeing enzyme levels, you cannot tell it's a cirrhosis or not. Cirrhosis can have an elevated enzyme or a normal enzyme. Cirrhosis can have a normal bilirubin or elevated bilirubin. So if I have elevated bilirubin cirrhosis, I tell it's a decompensated cirrhosis. If we have a normal bilirubin, I will call it a compensated cirrhosis. That's all. So bilirubin levels or enzyme levels is not going to tell you whether the patient is having a cirrhosis or not. It's always either you need to do a pathology where to prove severe fibrosis. Usually we don't do that, but in radiology, at least you need to prove that the liver has shrunken, and at the same time, your liver span is reduced, and at the same time, you see a lot of nodules in the liver, either micro or macro nodules. So that will tell you that the patient is having a cirrhosis. So it's more of that kind of diagnosis rather than diagnosing through the LFT. LFT will not be confirmatory of a cirrhosis. It can suggest you a cirrhosis if AST-ALT ratio becomes more than 1 in a chronic hepatitis patient, but it cannot confirm whether the patient is having a cirrhosis or not. Whenever the patient is having a cholestatic pattern, as far as cholestatic disease is concerned, which is very, very important. So in this condition, your ALP is elevated along with AST and ALT. So please see that this patient is having a cholestatic disease. I mean, already I've written that, so no need to worry. So cholestatic disease, whenever you have a cholestatic disease, the first thing I'm going to do is an ultrasound. It's quite important. So when I do an ultrasound, if I see a dilated duct, I can see a dilated duct, or I can see a mass lesion in ultrasound, or I can see a normal ultrasound, non-dilated biliary radicals. So dilated ducts, the ducts means I'm talking about biliary radicals, either intrahepatic or extrahepatic radicals. So any biliary radical is dilated. So whenever the ducts are dilated, it's always called as an extrahepatic cholestasis. Extrahepatic cholestasis. Whenever I see an extrahepatic cholestasis, typically next step is either a MRCP or an ERCP. MRCP is magnetic resonance cholangiopancreatography, and ERCP is your endoscopic retrograde cholangiopancreatography. Either ERCP or MRCP is something that has to be done because you're talking about an extrahepatic cholestasis, which means it's in the bile duct or probably in the periampullary region or probably somewhere else. So here, this is very, very important. Suppose if you know where in ultrasound itself, you clearly see a stone in the CBD, then straight away you can go for ERCP, no problem. Because you know there is a stone in the CBD. You can straight away do a ERCP and you can extract the stone. So it's a therapeutic as well as diagnostic procedure. So it's not a problem. But if you don't know the cause, so bile duct, you have extensively elevated, there's only dilation, but you can't see a stone, or probably you're not able to visualize what's happening, but just you can see there is a dilated duct. So in that setting, it's better to go for an MRCP. So you don't know the cause, you want to evaluate for the diagnosis, then go for MRCP. You know the cause, you want to treat it, go for an ERCP. So that is the idea. So any one can be fine. So I told you mass lesion, like a metastasis, or probably any other space occupying lesion could be there, like hepatocellular cancer also. We don't know. Some mass is there in the liver. So the next thing is triple phase or a triple contrast CT. Triple phase CT or a triple contrast CT is what you're going to do. So plus or minus, you might be needing to do an alpha fetoprotein, plus or minus, you might take a biopsy of the mass. So all these things are optional, but the most important next step is doing a triple phase CT. So if you see a mass, CT is the best for liver. And next thing is, if you have a normal ultrasound is suggestive of an intrahepatic cholestasis. Intrahepatic cholestasis, which means I'm not seeing any dilated biliary radicals. So it's an intrahepatic cholestasis. That's why I'm not seeing any dilation of biliary radical anywhere within the liver or outside the liver. So next step, there are many DDs are there, but the next step is to do a serum AMA, antimitochondrial antibody. So where you have to rule out a primary biliary cirrhosis, which is a very important antibody in TBC. Then carefully you need to evaluate drug history, because there are a lot of drugs I told you which can produce intrahepatic cholesterol. The most important being your OCPs, anabolic steroids. Then I can talk about a lot of beta-lactam drugs. In reality, few beta-lactams will produce extremely high risk of producing this intrahepatic cholestasis, like amoxicillin, clavulanic acid, cloxacillin, dicloxacillin, flucloxacillin. This cloxacillin group, these are extremely notorious. They can cause intrahepatic cholestasis, which can have a high bilirubin and all, but at the same time, you can have a cholestatic picture of enzymes as well. And next, we need to rule out sepsis also. Sepsis is also very important in this situation, because sepsis can cause a picture of cholestasis only. Usually sepsis, if they ask you, they typically tend to produce cholestatic picture only. So sepsis sometimes can cause bilirubin of 8, 10 and all, typically referred to as something called a cholangitis lenta. There is something called a cholangitis lenta. So this is not a true cholangitis, where typically the patient can have sepsis. Because of that, they can produce inflammation of the biliary radical. So that's what we refer to as a cholangitis lenta, where they can have bilirubin of around 6, 7 and all sometimes, where you have seen it typically looks like a cholestatic pattern. ALP will be too much elevated in that scenario also. So if you don't know what is the cause, you can go for the biopsy. Next step. This is the last step, but usually in this itself, you will be able to find out. So what is the usual cause? And there is one more cause. So typically if the patient is getting pregnancy, especially in the 3rd trimester, I'm going to talk about something called the intrahepatic cholestasis of pregnancy. It's called ICP. These are the usual causes. Pregnancy, 3rd trimester, you have cholestatic pattern, including jaundice. That's called the intrahepatic cholestasis of pregnancy. So this is how you evaluate a patient who's having a elevated liver enzyme. But please understand, this patient may or may not have a jaundice. Plus or minus jaundice can be there. In the sense, plus or minus hyperbilirubinemia. That can be there in this patient. I'm not talking about that in the first place. Fine, that's okay. So whenever the patient is having a normal liver enzyme, then your idea is completely different. So here, why you are actually, if you tell it's an abnormal LFT, you are typically talking about patient who's having either a jaundice, like for example, I'm talking about either a isolated hyperbilirubinemia, isolated increase in bilirubin with a normal liver enzyme, or I'm talking about a patient who's having a isolated synthetic function dysfunction. For example, I'm having an isolated low albumin, isolated decreased albumin, or I'm having a isolated increase in the PTINR, isolated increase in the PTINR. So this is what I'm talking about. So these are 3 scenarios that you encounter. Whenever I have an isolated hyperbilirubinemia in exam, usually it will be a congenital cause. See whether it is predominantly unconjugated or if it's predominantly conjugated. If it's predominantly unconjugated, I'll be thinking about Gilbert syndrome or a Crigler-Najjar syndrome. And if it's conjugated, I'll be thinking about a Dubin-Johnson syndrome or a Rotar syndrome. That's all. So whenever you want to diagnose this congenital causes of hyperbilirubinemia, always you have to know that the liver enzymes has to be normal. Liver enzymes will not be elevated, and there won't be any problem at all. Whenever there's isolated decrease in the albumin, you think about a non-hepatic cause. Non-hepatic cause. Very commonly, you might be encountering patients with chronic inflammatory disease like rheumatoid arthritis or SLE. And second, you can think about patients who are having malabsorption, nephrotic syndrome. So something will be there. So, I'm just telling some examples. So it's a non-hepatic cause, or it could be some sepsis sometimes, or CHF, congestive heart failure, where you can have a low albumin. So anything can produce low albumin. Usually it's a non-hepatic cause of low albumin. Whenever you have an isolated increase in the PTINR, everything else, the liver enzymes are normal. So one important point is there. If there is a prior history of acute liver failure, prior history of ALF, prior history of acute liver failure, where previously the patient had a ALF, where there was an elevation of enzymes, but now the enzymes have become normal, this can indicate something worse, that the patient has gone for a fulminant liver failure. Fulminant liver failure, acute liver failure are same, But I can write more than writing a fulminant liver failure. I can tell it's a worse scenario where the patient has gone for a total liver failure. I mean, don't worry about this new names that this is actually what I used personally for from my brain. There's nothing like a total liver failure. First of all, please understand, total liver failure in the sense like patient had acute liver failure. Now enzymes have become normal, but only PT INR has been elevated. Means it's a worse scenario because now almost all the liver cells have been destroyed, and there is no more enzymes that is left in the body. I mean, the liver to actually no more cells that is left in the liver to actually produce these enzymes. So enzymes have become normal, but PTNR alone has been elevated. So I'll be thinking about a severe liver failure in this situation, which means this is one indication for a transplant. So enzymes have become normal, but only my PTNR is significantly elevated. Usually here the PTNR elevation will be extremely high. INR may be more than 3.5, more than 6.5, it will be extremely high. So this is one condition that you need to know. Suppose if there is no history of prior acute liver failure, then in this situation you can think about a DIC where there will be clues which I told you, or it could be a vitamin K deficiency, or patients might be using a warfarin. So some cause could be there. So, but usually this is not a question exam. They won't ask you this. Don't worry about that. But in reality, I'm telling, suppose if the patient is having, I mean, to picturize this patient is getting a ALF, and at this point of time he's having an increased bilirubin, increased enzymes, or increased PTINR. But now he has got a normal enzymes, but still they're having high bilirubin and high PTINR, but enzymes have become normal. So this is a worse situation where why the enzymes have become normal is not because the liver has normalized. Here still the bilirubin and PTINR is high, suggestive of liver cell dysfunction, but the enzymes have become normal because there is no longer there is enough amount of liver cells to actually produce these enzymes in the first place. So it's a sign of a very severe disease. So this is something you need to know. Apart from that, I don't think they will ask you again that in exam. So you can really forget that, but that's not important. But just for understanding sake, I told you. So this is a complete evaluation of liver function test. But even though there is so much of overlap between them, in reality, it's not that simple to evaluate in a LFT. You need to take so many things into consideration. Especially the history is something that is often forgotten by the students, which should not be in the first place. But nevertheless, so this table will be very, very useful for you. So how to evaluate each and everything. But remember, the most important thing I need to substantiate again and again is the mass lesion. So that's going to produce a cholestatic pattern only. Arshad is asking, sir, won't enzyme level lower at any cost once liver cell fails? That's why I told you. I mean, if the liver cell failure is there initially at the earliest stage of liver cell failure, you will have elevated enzymes only. I think I've rubbed that off. Okay. In earliest stage of liver cell failure, your enzyme levels will be actually high only because there is something called half-life of the enzymes. In acute liver failure especially, your enzyme levels will be actually quite high. So because till that half-life is over, your enzymes will be elevated only. But once there is a significant amount of liver cell failure that has happened and liver cells have been destroyed, now the enzymes, once their half-life, 2 to 3 half-lives are over, then the enzymes will start dropping, and only the liver cell failure pattern will be there, like elevated PTNR, encephalopathy and all may be there, but the patient might have completely normal enzymes. That's what I'm trying to substantiate. So normal liver enzymes does not rule out a liver cell failure. So the final take-home point of this particular entity is a normal liver enzyme does not rule out a liver cell failure, or a normal liver enzyme does not even rule out a cirrhosis for that matter. Similarly, elevated liver enzyme does not mean it's a liver failure, or elevated liver enzyme does not mean it's a cirrhosis. So enzyme elevation should be seen as a injury, and liver cell failure should be seen as a separate entity, that coagulopathy and encephalopathy. So these are the final take-home points that you need to know in the first place. I think even though this is quite complicated, I think you can understand. Can you understand? If you understand, we can move on to the next one. Clear. Fine. So let us move on to the different types of jaundice that you really see. As far as the jaundice is concerned, you know that. So what will be we have something called a prehepatic jaundice. Prehepatic jaundice. And you have something called a hepatocellular jaundice or intrahepatic jaundice. And you have something called a posthepatic jaundice. Usually prehepatic jaundice will be due to this thing only, hemolysis only. But there are many other causes. Pre-hepatic jaundice is hemolysis. Typically, you'll have an unconjugated bilirubin that is elevated. Unconjugated bilirubin that is elevated. But I mean, we can go methodically rather than writing this badly. We can go methodically. What is the bilirubin that is elevated? Bilirubin that is elevated, that is predominantly unconjugated type. In post-hepatic, it will be predominantly conjugated type. Whereas in hepatocellular jaundice, it's most of a mixed type of bilirubin elevation. So how will you know it's unconjugated, mixed, or conjugated? You need to have some kind of objective value. It's not subjective, it's more of objective. So there should be some cutoff. For example, we take something called a DB by TB ratio. That's called a direct bilirubin by total bilirubin ratio. If you take this, if it is less than 20%, what do you mean by this? If the direct bilirubin is actually less than 20, but the indirect bilirubin is more than 80%. So if this is the case, then it's purely unconjugated bilirubin, pre-hepatic jaundice. If it's hepatocellular, means it will be mixed. DB by TB ratio will be in the range of 20 to 50%, which means direct bilirubin, that is conjugated bilirubin, in the range of 20 to 50. Typically in post-hepatic, it will be more than 50%. Clear? As far as your bilirubin in urine is concerned, urinary bilirubin. Remember, urinary bilirubin will be based on your conjugated bilirubin presence. Whether conjugated bilirubin is there or not, that is the question. So if it's a pure post-hepatic jaundice, the urinary bilirubin is going to be extremely high, because this is the situation where it's going to have a very high level of conjugated bilirubin. But here it will be elevated, but not be that much. But many of the times in pre-hepatic, it will be normal or only mild elevation will be there, because it's more of an unconjugated bilirubin which cannot be excreted in the urine, basically. So that's the idea. And next, if you see urobilinogen, this is the point. As far as urobilinogen is concerned, I mean, it's quite reverse. It's exactly opposite. As far as urobilinogen is concerned, your unconjugated bilirubin, I mean, pre-hepatic jaundice will produce maybe normal levels or increased levels of urinary urobilinogen. And once again, you might have a normal or increased levels of urobilinogen if it's a hepatocellular jaundice. But on the other hand, if it's a post-hepatic jaundice, it will be absent. This is the most important point. Because as I told you in obstruction, because post-hepatic jaundice is typically due to obstruction. So whenever there is obstruction to the bile flow, I told you this intrahepatic circulation will be lost and you will have an absent urobilinogen in the urine. So that's why seeing bilirubin in the urine is different from seeing urobilinogen in the urine. So urobilinogen is a marker of intrahepatic circulation, not marker of bilirubin in the urine. So many students, I don't know, you might be brilliant, but many students, even now, they tend to confuse between this, like urobilinogen versus a urinary bilinogen. So both are completely different. And typically, what about the liver enzymes? Liver enzymes are variable in all. If it's hemolysis, usually it will be normal. Liver enzymes, there will be no problem. So typically, you will have a hepatocellular pattern here. Hepatocellular pattern. Most of the times it will be normal, liver enzymes. Typically, you will have an hepatocellular pattern. Here you'll have a cholestatic pattern. So this is a normal. I mean, there are considerable variations here. You should not equate jaundice with your hepatocellular pattern or cholestatic pattern. But nevertheless, typically in patients who are having post-hepatic jaundice, they tend to have a cholestatic pattern. Whereas patients who are having a Harshin is asking urinary bilinogen, urobilinogen. No, urinary bilirubin. You're talking about a urinary bilirubin, not bilinogen. Urinary bilirubin is different from urobilinogen. Urinary bilirubin means we are talking about a conjugated bilirubin. Urinary urobilinogen is a completely different entity. So that's something that should not be equated to urinary bilirubin. That is conjugated bilirubin. Both are different. Urinary bilirubin means how much conjugated bilirubin is coming into the urine. So that's different. Urobilinogen is basically a marker of intrahepatic circulation. That's different. So typically, liver enzymes will be normal in majority of the true pre-hepatic jaundice. The liver enzymes will be normal. For example, hemolysis. Some drugs can cause this, or probably you can think about what else is there? Yeah, some congenital causes. In most of these conditions, the enzyme levels will be normal. Many of the times, if you have mixed pattern, you will get a hepatocellular pattern of jaundice, hepatocellular pattern of enzymes, where I told you AST, ALT will be elevated more than 3 times, but ALP will be less than 2 times. Most of the times in conjugated hyperbilirubinemia, you will get a cholestatic pattern. But remember, enzymes can be normal in congenital conditions. Congenital disorders like Dupin-Johnson and Rotor, enzymes can be normal. So enzymes are quite variable, but nevertheless, this is the usual pattern because congenital causes are very rare to really see in reality. But but nevertheless, this was something that you need to know. Without, if there is enzyme elevation, you cannot diagnose a congenital cause of hyperbilirubinemia. This is some table that is very important. So in the entire table, if there is one point that you need to know, that this is the point. So urinary urobilinogen is absent in cholestatic jaundice, or any post-hepatic jaundice or obstructive jaundice, urinary urobilinogen is absent. Very, very important. This is true for all post-hepatic jaundice. If there is no bile flow, no intrahepatic circulation, no urobilinogen. This is something that is very important to know as well. So let us discuss some of the few causes of congenital hyperbilirubinemia. Before that, just hold on 1 second. I'll just have something to do. Just hold on. I'll come back in a couple of minutes.